right, I'm really pleased to have with us today Dr. Dukelow and Dr. Jennifer Semrau, who developed the kinesthesia task, which we, Kinarm, have just released as the arm movement matching task as part of our Kinarm Standard Tests suite. So we've gathered him here today to talk about the history of the task and to understand a little bit more about why it was created and how it's used and what they found with the task. So I thought I should just actually start by asking both of you if you could introduce yourselves and what your research interests are. Sean, would you like to go ahead?
Sure. I'm a clinician scientist at the University of Calgary. I'm a physician who specializes in physical medicine rehabilitation, and most of my clinical work involves stroke. And we were interested in, or broadly interested in, assessment of impairments, sensory motor and cognitive impairments following stroke, which is how we got involved in this particular task.
That's great. And Jen, would you like to introduce yourself?
Sure. I'm an assistant professor at the University of Delaware, and what we're going to talk about today was something that I worked on when I was a postdoc with Sean at the University of Calgary. Currently, my lab focuses on trying to understand the different sensory components of deficits using robotics and a Kinarm in people with stroke.
That's great. So Sean, maybe I thought we'd start with you and help sort of frame for us the clinical issue. Why is kinesthesia so important?
Sure. So, when we're assessing a patient after they've had a stroke, one of the things we're trying to do is quantify their impairments across different domains. And when we look at motor function, say in hemiplegia, we have a number of ordinal scales that we'll use to measure that. And those are pretty commonplace clinically around the world. Now, when you get into the sensory side of things, and in particular looking at proprioception, there's only a few very simplistic tests that get used. And one, for example, is taking the patient's finger or their toe at the distal interphalangeal joint and either moving the tip up or down, and asking the patient which direction it moved in. And that's a common clinical exam that physicians or other clinicians will use to try to determine whether somebody's got a proprioceptive deficit and whether it's a deficit in movement. And so it's not a particularly unbiased assessment of how things are going. You ask the patients to close their eyes, and often when we're doing it, we find the patients will be opening their eyes and visually telling you, yeah, it moved up or it moved down. So we wanted a good way to try to quantify kinesthesia, or your sense of movement and speed and direction, that was reliable, and that we could have more than one trial when we're doing something, as we often only do a single one in clinic, that could say, yes, there is a problem with proprioception or kinesthesia in this patient. And so that was the impetus, I think, for developing the current task.
Which is great. You sort of touched on, how you were attempting to assess that particular proprioceptive deficit in the clinic right now. I'm curious as a layperson, what does it look like to have somebody with a kinesthesia deficit? How does it affect their behavior,
Yeah,
in a real world way?
so it's an interesting thing, because motor deficits broadly, we'll assess someone's strength, or we may look at how they move, and we'll have these patients who can have preserved strength, but the clinical team working with them, and even their family members and the patients themselves, say, I move funny, something's wrong, I'm not moving this way. And so it's almost like clinically it can go and be unrecognized unless somebody's very attuned to having seeing patients with proprioceptive impairments. And so we just didn't have a good way of being able to pick it up in terms of making a diagnosis. Yes, there's a proprioceptive impairment. And clinically, with you're moving someone's finger up or down, you may be looking at their CAT scan or their MRI, saying, well, sensory cortex is impacted, so it's likely this is a proprioceptive deficit. But you always felt, or I've always felt, like you fumble a little bit because we don't have a good diagnostic test for proprioceptive impairment.
And at the time that you started developing the kinesthesia test, you've been using the Kinarm for a while, and so I was curious about how did you sense that the Kinarm would be useful in sort of assessing this type of impairment?
Yeah. So when we started, we'd done work with and developed the arm position matching task, looking at position sense. And over the course of developing that, I came to realize that the robot was able to make movements reliably and repeat them more so than I could do in my clinic by moving someone in a given direction, ask them where I'd stopped. And so it made me realize that if you want to do things right, you really need some sort of mechanized device that can do things repeatedly. And then as we got into looking at just position sense, I began to realize that, for movement, and these patients who come in who look like their movement's impaired, but on the bedside exam, they've got good strength. We needed something better to assess one of the other aspects of proprioception, which is kinesthesia.
Right. That makes a lot of sense. So maybe I'll switch, Jen, now to you at this point. And I'm curious, in the actual task itself, what are you measuring?
Well, and so, Sean just talked a little bit about the development of the various tasks with the Kinarm, so the arm position matching task, and then, what we refer to as the kinesthesia task.
Yes.
And so the first, I guess, round of investigation was looking at, the static position of the person's limb in that arm position matching task. And Sean was just talking about, we were really interested in measuring whether or not someone could perceive that their movement or their arm was moving. And so, what we really are measuring is, can someone detect that their arm is moving, and can they do it in an accurate way? And so, can they match a movement of the robot? Can they actually detect which way it's going, how far it's going, or even how fast it's going? And so those are the different types of parameters that we use to really quantify whether or not someone is going to have intact behavior or impaired behavior when we compare them to, a variety of control collections.
Right. And I realized too, maybe it'd be useful to sort of actually describe the task as how it is perceived by the subject. Would you like to do that?
Sure. And so in this particular task, when we were, the kind of the nuts and bolts of it are, the robot moves the person's, for stroke individuals, moves the person's stroke affected arm at a preset speed, direction, and magnitude of movement. And then with their opposite arm or their less affected arm, they're supposed to mirror match that movement exactly. So the speed, the direction, and the magnitude of that particular movement. And so we use the stroke affected arm as a reference. So that, we are referring to the arm that we think is likely impaired, that actually has a lot of difficulty detecting movement. And so what we're doing with that less affected arm or unaffected arm is that we're using that as the behavioral output and seeing, can the person reproduce that movement similarly to what they felt or what they sensed.
Sensed in the affected arm. No, very good. That's a great description, actually. I know you have looked at a lot of data over many months of being collected. And what differences in performance did you find for those with stroke as compared to healthy controls?
Well, first, I'm flattered that you think that we collected all the data in months, overestimating our ability to be speedy. But over the course of years in Sean's lab, and Sean's lab continues to collect this data. Sean can correct me if I'm wrong, but we had hundreds of participants that performed this task, hundreds of participants with stroke, as well as hundreds of participants that were neurologically intact controls. And so one of the things that I typically say is that if there is a odd pattern of behavior, we could probably find it for you. And so we see the gamut in individuals with stroke. We see people who don't show these types of impairments in kinesthesia. We see people who have very mild impairments in kinesthesia. And that's actually one of the huge advantages of the robot, is that, it's being able to detect sensitively people who may have these more mild to moderate impairments in kinesthesia. And then we have folks who have no idea where their arm is at all. And in fact, when we would collect data from subjects, I remember one gentleman in particular who actually told uh, the, the physiotherapist in the lab at the time, she was concerned that he didn't understand the task. And he told her that I can't feel where my arm, I can't feel my arm, I can't feel the robot move my arm. And so you do get this very, very broad range of behavior that ranges from completely intact to wholly impaired. And so the robot gives us a very nice objective way to be able to quantify those different types of behaviors.
Right. And over what period of time would you typically follow those subjects with stroke?
So for many of the studies that we completed in Sean's lab, we were looking at individuals who had subacute stroke. And so that's individuals who are within the first 6 months post-stroke. Many of those individuals we collected data from in the first week post-stroke. So anywhere from 1 to 10 days post-stroke was typically our initial collection timeline. And then we were conducting a longitudinal study and looking at how that behavior evolved over time. And so we would collect data at that first time point, which was about 1 week post-stroke, and then again at 6 weeks, 3 months, and 6 months to look at how this behavior evolves over the course of recovery.
Right. Which was exactly what I was going to ask. As the next question. How do you see subjects recovering with kinesthesia over that sort of period of time?
And just like the variability that we see in the performance of individuals, we see that type of variability within individuals as well.
Right.
And so we see many people who recover very quickly within the first 6 weeks. Their kinesthesia goes from impaired to not impaired as they recover throughout their stroke. We have individuals who show little to no improvement over the course of 6 months. We have people who show gradual improvements. We have people who show steep improvements. And that timing really depends on the individual and their specific impairment profile.
Right. So it must be so incredibly heterogeneous, a lot of heterogeneity in terms of the outcomes of the recovery process for that particular type of deficit. And, I'm sure, knowing that you're looking often at a battery of different tasks and different behaviors and performance across the time spectrum, how did you find that recovery compared to other impairments found, say, with also using the Kinarm or through other means?
Yeah, and so one of the studies that we published was one in 2015 where we looked at exactly that. We looked at the relationship between several of these proprioceptive impairments and compared them to motor recovery. And so we find that for some folks, that when we look at some of the tasks that quantify motor recovery, like the standard visually guided reaching task or the object hit task, that those proprioceptive impairments in kinesthesia and position sense kind of follow the same trajectory for some folks. But there are many individuals with stroke that actually can have intact motor control, but impaired proprioception and vice versa. And so, I think that's where the importance of the objective quantification of these types of deficits really speaks out, because Sean was talking about individuals who feel like they're a little funny, right? And so you can have these individuals who really don't have an issue producing movement, but they may feel like they're not coordinated, or they're having kind of just a little bit of difficulty navigating. And that may be not necessarily a motor production issue, it may be a proprioceptive issue.
Sure, sure. And before we maybe talk about sort of, what the future might hold for somebody in terms of a therapy, I'm curious to maybe ask that question, Sean, of you in terms of what other, what other indications, whether they're neurological diseases or injuries, have you used the kinesthesia task to look at impairments post-event or in progress of decline?
Yeah, so quite a few actually. We've looked at some individuals with traumatic brain injury, both early and more chronic. We've looked at some individuals with spinal cord injury, although we haven't published that data just yet. We've examined a large number of children with perinatal stroke and cerebral palsy. We published a paper with Zelma Kish. Jen was the lead author on that, with patients with essential tremor. We've more recently started looking at some patients with dystonia. So we've used it on a number of different sort of patient groups that have come through for us to test, because, you know, in many of those other groups, it's also recognized that we're kind of missing part of the puzzle when we're trying to understand why the patient isn't moving the way either we think they should be or they think they should be.
Right. Yeah. So do you foresee, you know, there's a big, you know, puzzle here, pieces still to be put together, but do you foresee the time when this may be actually something that will have utility sort of beyond the most immediate research goals? Do you foresee that it might actually be used in a sort of more regular way, or even in the development of therapy?
Well, I think broadly, in order to measure proprioception and do a good job of it, we are going to need an instrumented method. And certainly the robot provides a way of doing that. Because of problems with reliability, because of problems with the way we've done things clinically. And so from that perspective, yes. And in part because I think increasingly we're recognizing that these sensory deficits or proprioceptive deficits that we kind of pick up on sometimes after we probably should clinically are important, and that particular patient who's in front of me may not be recovering like we thought because of everything that Jen's just talked about, because there may be a substantial proprioceptive deficit, and because of that, they're not recovering as you know, as someone with an isolated motor deficit.
Right. So do you foresee that, you know, can you actually develop therapeutic interventions, or is it still too early to see? You know?
Yeah, so it's an interesting idea. So I mean, in our group, we've got some studies going on right now with some non-invasive brain stimulation to see if we can try to improve things. We've also got some...
and that being in stroke, I presume?
Stroke, yeah.
Primarily, yeah.
And then we've also got some work going on where we've developed tasks that are targeting individuals with proprioceptive loss and seeing if that may be helpful. And there's other groups around the world that are working on this problem too, you know, using things like a vibratory stimuli to try to improve proprioception. And there have been case studies in the past which have looked at electrical stimulation. So to try to get some other sensory stimulus to either enhance recovery after stroke of the proprioceptive system, or to serve as a bit of a sensory substitution. So people are thinking about it. It's not anywhere close to as far ahead along the spectrum of things as, you know, therapy for motor deficits.
Sure. No, it's interesting. I think you both have provided a fantastic synopsis and of all many years of research and work and many publications. Is there anything that you'd like to mention that I haven't asked?
Jen, do you want to go?
Well, I think the biggest thing is that this is just the beginning in terms of our understanding of these kind of proprioceptive impairments and stroke. And I think that, you know, sometimes we lose sight of how little we know about these different types of impairments. And so I look forward to the next chapter of trying to figure this out.
I think I agree. I think that, you know, we started with position sense. We moved into this sense of movement or kinesthesia. We've done a little bit of work in another sense called sense of effort or sense of force. And we're in a lot of ways in a really exciting time, because I think there's a lot more to understand about how sensation, proprioception gets integrated into the brain with your other senses and your motor system. and that a lot of the impairments that I see day to day with patients may be coming from problems with aspects of sensation that were really previously underappreciated, or the integration of them.
It's exciting optimism for the future, something we all need right now. Yeah. Well, thank you both for spending your time with us this afternoon, and it's a great update, great say, hope for the future, and hopefully we'll encourage some people to try out the new arm movement matching task that was released in Dexterit-E 3.9. So thanks again very much.
Thanks, Anne.